Let's get going. Okay, no conflicts of interests here. So this is essentially the take-home message for the entire 45-minute session today. If anyone feels that this is standard practice at your shop, you could, I'm not sure who left this, but it's free to pass around if you want to just sort of take another nap here. At my shop, it's certainly not a battle won. 40% of our patients, or DISI patients, I should say, get a CT. The paradigm of CT equals diagnosis, it's so strong, probably because it's true in very many other situations, right? But it's not true for nausea, as I'll show you later. Until last year, my own department didn't even have the correct equipment to work up a DISI patient, the Frenzel goggles. I would like to think that no one in the room is in that situation today. If it is the case that you don't have access to this piece of equipment, you're going to have to call your boss straight away. Just pick up your phone now, because it's absolutely essential. Based on the scientific evidence only produced for the last 10 to 15 years, so this is really new stuff in medicine. You know, it takes an average of 11 years or something like that for evidence to diffuse into standard practice. So it's understandable if there's some lag in the implementation of this knowledge. However, given how universally conformative, conclusive that this evidence is, there's really no excuse to have suboptimal workup of these patients anymore. My goal today is to make all of you advocates for this new approach to DISI patients. I want you to go home to your departments and implement this, if it's not already been done. There are only 3 things that you need to work up a DISI patient correctly. The first thing you need is some type of algorithm. We'll touch on which algorithms are available, but you're going to have to choose at least one. Frenzel goggles, get them if you don't have them. And then you're going to have to learn a sort of a subset, a limited amount of clinical tests. They're all tests that anyone can learn. If you have a working pair of hands, good eyesight, and the adequate training, you're going to be able to perform these tests very, very well. We'll go over the indication for each of these tests, but we won't be able to go into details and not practically train this. And all of these tests have to be trained in order to be able to perform them correctly. So it's important to have a local program for this. And if you don't have that, try and implement it. If you don't know how, just email me and we'll figure something out. I'll show this QR code at the end of the lecture. Leads you to all the references as usual, and there's also an email address there where you can reach me. All right. I always find it easier to illustrate the point with clinical cases. So I think we're just going to start off easy with a case that most people would feel quite familiar with and been exposed to previously. When we run through the case, I want you to focus on how the information from the history and the examination sort of guides us through the algorithm, and notice how details around timing and trigger prompts us in the right direction to the correct test. All right, so this is a 69-year-old lady. She went out in her garden managing her roses when she suddenly got horribly dizzy. She sat down to rest and the dizziness got better, but when she stood up again, the dizziness came back. She didn't trust herself to be home alone like this, so she called an ambulance. She doesn't have any other complaints, no headache, chest pain, abdominal pain, no shortness of breath. She denies any double vision, difficulty swallowing, altered voice, difficulty talking, hearing problems, or clumsiness. When she's not moving her head, the dizziness disappears. She has stable vital signs, her general and neurological examinations are unremarkable, and there's no hearing loss. The history does not point to any systemic disease producing dizziness, and everything else in the examination and the vital signs seems to be okay. So from the history, it's evident that this, although the patient might feel a bit sort of dizzy and nauseous in between, but the dizziness is episodic as such, not constant. So we'll go into the upper leg of this particular algorithm, and from this point, there's no crossing over between these two legs. It's also evident that head movement is a trigger of this patient's dizziness. It's not spontaneous, it's triggered. A quick check with the frontals to rule out spontaneous nystagmus is always prudent, but we're not expecting that in this particular case, obviously. The timing and the trigger prompts the following tests. She doesn't exhibit any signs of orthostatic hypotension during the Shellongs, so we proceed with the Dix-Hallpike. And when we do that, the patients start feeling dizzy after a few seconds of latency. We observe a vertical, torsional, upbeating nystagmus that lasts for less than a minute. So the test is positive and gives the diagnosis of posterior canal BPPV. You can see that the presence of a trigger here steers you away from the possible diagnosis of a TIA. In the absence of a trigger, we would have a spontaneous episodic dizziness, and then TIA would be a differential. And one sort of fun fact about TIA in the posterior circulation, it's not recognized as a cause of isolated dizziness among neurologists. And this is probably not true. You can likely have TIA presenting as isolated dizziness, but it's not something that you automatically can sell to the neurologist. For it to be a TIA, it has to be some associated symptoms with this dizziness. So at least it's very rare, and it shouldn't be one of the primary concerns with any dizzy patient. Let's interrupt for a question. There you go, catchbox.
On, right. Yeah, about the TIA. I've had this discussion with a few neurologists, and they all say they've never seen it, and I've never seen it. It's probably because we don't look for it. If it's a vertigo that's for an hour or something and then goes away. I'm just curious, has anybody seen it or diagnosed it?
Gerald has an answer.
I think the clue is the history.
Answer the question. Have you seen it?
Yes, I've seen it, but not in isolated dizziness.
Exactly, yeah.
But chief complaint for the patient's dizziness. I had episodic dizziness, but when you drill down, there will be always something else, like double vision, speech difficulty, everything that's represented on the posterior circulation, but not isolated, no.
So that's certainly true in the literature. We do have some cases in the articles that we'll go through that sort of have the diagnosis of TIA even for isolated dizziness sometimes, but it's really rare, shouldn't be your primary concern at all. So as you pointed out there, Gerald, it's really important with the history and the examination to sort of dig down into any associated symptoms or subtle neurological deficits in this. All right, so at this point, we've safely and accurately managed our first dizzy patient using only history, examination, and a clinical test. So we now have some time to discuss the general pre-test probability of stroke among dizzy patients. This is, I find, quite good study. It's from the States, Texas, and it only includes patients presenting to a non-referral hospital, so sort of a true sort of community-based cohort. They included 1,666 patients with a principal presentation complaint of dizziness, vertigo, or imbalance. 53 patients, or 3.2%, were ultimately diagnosed with stroke or TIA. So the general pretest probability would be around 3% in this cohort. 1,297 patients had isolated dizziness, meaning that they didn't have any neurological deficits on the neurology exam. The prevalence of stroke or TIA among these patients were 0.7%. So really, really rare. In this study, including 163 patients from my own hospital, Landspitali, which is a referral center, the prevalence of stroke among patients with the main complaint of dizziness was 3%. And in this study from Umeå, also on ED patients with the main complaint of dizziness, examining 2,126 ED visits, 2.9% were diagnosed with stroke and 1.9% with TIA. So the number seems to be quite sort of universal. Let's have a look at the rate of CT scans ordered in these studies. In the American study, they didn't explicitly say how many had a CT scan, but they did mention that 2 didn't. So probably everyone else had one. Right? And they report that among the 1,297 patients with isolated dizziness, they were able to identify 1 hemorrhage. 1 hemorrhage. In the Landspitali study, 65 patients had a CT scan. 6 scans depicted some type of pathology, but only 2 of these pathologies or lesions judged to be capable of producing the patient's presenting symptoms. And only 1 of these patients had isolated dizziness. The other one had obvious neurological deficits. It doesn't state if these lesions were hemorrhages or not. In the Umeå study, 891 CT scans were performed. There were 3 cerebellar hemorrhages identified. For the CT scans performed on patients with isolated dizziness, 3.4% revealed some form of intracranial pathology, but they don't report on how relevant these findings were. The point, obviously, is it's exceedingly rare for patients with dizziness, and particularly isolated dizziness, to have any positive findings on a CT scan. All right. Let's just have a look at the other case. This is probably also something that you're used to see and getting exposed to frequently. Again, just try and focus on the timing and the trigger, how that guides us towards the appropriate test, and how that in turn then helps us towards a conclusion. This is a 39-year-old, previously healthy male. He practices triathlon, so physically quite fit. He was passing through the city on business when he fairly suddenly got dizzy while driving. He had to stop the car, and the dizziness just got worse and worse over the next 20 minutes. When he shut his eyes, he felt some type of relief. As soon as he opened the eyes, the dizziness just got overwhelmed him, but he was constantly dizzy. There was no way he could keep driving, so he actually called an ambulance, and now he finds himself in the emergency department on stroke alert. During the ambulance transport, he vomited several times. He doesn't complain of any headache or any other associated symptoms. He's slightly tachycardic, but otherwise normal vital signs. General examination is unremarkable, including the examination of both ears that look normal. He's neurologically intact besides having severe problems walking. The dizziness in this instance is constant, right? He's always dizzy, regardless of position or movement. There are things that can worsen the dizziness, but he's constantly dizzy. And there's no obvious trigger here, like a head trauma or intoxication or something like that. So it's spontaneous. And when we examine him with our frontal goggles here, he has spontaneous, horizontal, right beating nystagmus with a small torsional component. This gets worse on looking to the right and better on looking to the left. At this stage, it's very common for physicians to want to rule out a stroke with a CT scan, but we won't do that this time. Instead, we'll consult our algorithm to find out what the appropriate test is for a constant dizziness without any trigger. With that presentation, it's the hint exam that we're supposed to do. The hint exam, as you are very well aware, stands for head impulse test, nystagmus, and test of skew. To add sensitivity, most clinicians add a plus at the end, so it becomes a hint plus exam. And the plus is there not to forget to check the hearing for any acute hearing loss. And that adds extra sensitivity for ICA infarctions. So can emergency physicians perform this hint exam? This 2020 systematic review suggests that emergency physicians struggled with this. But this conclusion was based on one study, single center, 272 patients recruited between 2009 and 13, not all examined by emergency physicians, and Frenzel goggles were only used in less of half of the cases. This new meta-analysis shows that non-neurologists can achieve adequate sensitivity, provided that they had adequate training. Again, emphasizing the importance of practical experience in performing this test. Yeah, that's all well and fine, you say, but I don't feel comfortable ruling out a stroke in this case unless I have a negative CT, some might say. All right, let's have a review of how a negative CT impacts post-test probability. Using this free online calculator, we can easily find out. Let's choose 10% pre-test probability. In this case, it's probably a bit lower than that, but if you play around with this calculator, you'll notice quite soon that it doesn't really matter. The post-test probability will never drop to an acceptable level, unless the pre-test probability is already acceptable. The sensitivity and specificity is from the latest systemic review. And as you can see, CT is not able to rule out stroke in this case. And that's true for any other case with isolated dizziness as well. Emergency physicians' failure to realize this has led and are still leading to stroke patients being misdiagnosed and sent home. A CT does not decrease the risk of a dizzy patient having a stroke in a meaningful way. This is really important to remember. All right, but how about the specificity? It looks excellent, isn't it? Isn't it good just to do a CT and see if it's positive? Remembering the numbers from the US study, Landspitali study, the Umeå study, we now know that it's exceedingly rare for a CT to be in any meaningful way, anyway, positive in a dizzy patient. You would probably have to do in the vicinity of 100 scans to find any pathology and up to 1,000 scans to find a hemorrhage. There are additional studies supporting this conclusion. So it's not meaningful to try and produce a positive CT scan either for these patients. So CT is not indicated for isolated dizziness, period. That's my first sort of 100% true take-home message. It's never indicated for isolated dizziness. If you have a lot of associated symptoms, you might consider it, but it's still quite unlikely that it will show the lesion. And you can still not depend on it to rule out a stroke. All right. So instead of doing that CT, we do the hints. And when examining the nystagmus with the Frenzels, we can see a non-directed changing horizontal right beating nystagmus with a minor torsional component that increase on looking to the right and decrease on looking to the left. This is consistent with a peripheral lesion. When testing the skew, we find no significant vertical correction, and on performing the head impulse test, we notice a correction saccade when we test the left ear. We tested the hearing previously, so we know there's no acute hearing loss. Do you see that? It's quite obvious in this case. It's not always this obvious. There you go. All right. So with this, we conclude that the patient suffers from a vestibular neuritis and can be managed accordingly. We have arrived at this conclusion using history examination and a limited amount of clinical tests, in this case 1. We'll jump straight into our next case. We'll use the same algorithm to guide us through the process, emphasizing timing and trigger of the dizziness, applying the appropriate clinical test, arriving at a conclusion. This is a handover from the day shift that we haven't been able to reassess until now. It's a 67-year-old guy with hypertension, diabetes, and he had spontaneous onset of vertigo when he got up of bed this morning. He had some small episodes of dizziness the day before, but they only lasted for a couple of minutes, so he didn't think much of them. But this time, waking up, the dizziness didn't go away. He couldn't eat breakfast due to nausea. He needed assistance walking to the ambulance. And the initial examination did not reveal much according to the handover, but they suspected a stroke, so they ordered a CT scan and asked us to follow the result up and send him home if it was negative. The CT scan, as you might expect, is negative, but the patient's still dizzy and nauseated. So we go back from the start, we find our algorithm and start from the beginning. We get a good history and performed a detailed examination. We conclude that he has constant dizziness with a spontaneous onset, and we now know that the correct test again is the HINTS plus exam and nothing else. Using our calculator again, this time boosting the pretest probability up to 25%, because he has a lot of risk factors here. We can again see how poorly the CT performs if we were to do it. A negative scan does not decrease the risk in any meaningful way, in this case either. However, if we, as trained non-neurologists, perform a HINTS exam, we cut the risk all the way down to around 2% with a negative likelihood ratio of 0.06. With that number, I would personally feel safe to send a subset of these patients home, and the rest I would probably refer to ENT for some additional testing with caloric test or something like that to try to decrease this risk even further. But in this particular case, when we do the HINTS exam, we're unable to produce a correction saccade. With this, the probability of the patient having a stroke increases dramatically, as you can see. If I were to do a head impulse test on any of you in the room today, I would not be able to produce a correction saccade, and that would obviously be very comforting in this setting and perfectly reassuring. But in the context of acute vestibular syndrome, it's a bad thing. So this is why you can only do the head impulse test on a patient with acute vestibular syndrome, and only on patients with acute vestibular syndrome. If you haven't established that the patient has acute vestibular syndrome, that patient it will be impossible for you to interpret the result because you don't know what you're testing. So let the algorithm guide you towards the correct test in the correct setting. Okay. The patient still does not need a CT of any kind, but the patient needs to be admitted to neurology and have a confirmatory MRI scan 48 hours from now. Why can't we just get the MRI straight away and have it done with? Why does the patient need to wait 48 hours? So that's because even MRI is insufficient in sensitivity the first 24 hours. So it performs poorly when it comes to excluding a central lesion as a cause of isolated dizziness, if done early. Yet again, going back to the CT, we can see that it performs equally well or bad as a neurological examination in ruling out a stroke in this in acute vestibular syndromes. And looking at the full table, we can clearly see that the HINTS plus battery is vastly superior when it comes to ruling out stroke in acute vestibular syndrome. The numbers in red are for trained non-neurologists, and the numbers in black is what expert neuro-ophthalmologists are able to achieve. I haven't seen any study with a pretest probability of 75%, but I suppose if you have an old patient with all the risk factor, you could arrive at that estimation, but mostly will trot around in the vicinity of 1 to 25%. And in those cases, HINTS perform excellently. Could you pass the mic backwards? All the way up in the back. There we go. Brilliant.
Hi, I mean, that case, the last case you discussed now, I mean, the suspicion of stroke is kind of increased because of all this test and the risk factors and such. So where I work, we wouldn't be satisfied with just a native CT or wait 2 days, 48 hours for an MRI. We would do a CT scan with the large vessel neck vessel contrast, or even with the various perfusion scans.
I know. So perfusion scan has lower sensitivity than a native scan, at least in the literature. It doesn't make much sense to me, but that's what the literature says. I don't see any indication for this, and it is really in the guidelines from 2019, basically. So, yeah, we have an additional question there. But I understand the issue with neurologists not being up to speed with this. So that's why we really need to be convinced and understand why we're not advocating for a CT scan.
Man ska ju göra en CT-hjärna för att utesluta blödning när man sätter in trombocythämmare.
Right.
Så där har du en indikation för CT.
Yeah,
fast det egentligen inte handlar om diagnostiken.
Right. So if you want to do 1,000 CTs before you find one bleeding, that's up to you, but I don't see that benefits the patients as a whole. But obviously you can have that discussion locally. Okay, that was a deep dive into neuroradiology, and I understand that that's very difficult, a difficult discussion to have. That's why I'm really sort of focusing on that a lot of in the presentation. So please have a look at the literature yourself and the guidelines, what the recommendations are. Anyway, let's zoom out a bit and just go back to the 3 tools that I was talking about initially. The first one I mentioned was the algorithm. I hope that I've been able to show how important it is to let yourself be guided by an algorithm when you work up a DISC patient. Most of the time we're used to collecting all the examinations and tests simultaneously and then try to synthesize a conclusion out of all the information at the same point. That's not possible with a DISC patient. In the DISC patient, you're going to have to adopt to a stepwise approach because the algorithm will lead you to the correct test. It's very common for colleagues, specifically junior doctors, coming to me and saying, okay, I have this DISC patient, I've performed the Dix-Hallpike, I've done the hits, and I don't know what to make of this. And you know, if you just let them have an algorithm, they'll be able to guide themselves through, and they'll discover that there's no presentation in the ED where it's appropriate to do both Dix-Hallpike and the hit on the same patient. There are several algorithms out there. Just going to have to choose one or synthesize one that feels good to you. I personally like the titrate, but it's also most comprehensive and complicated. So the standing protocol is quite easy and validated, so you could also use that. There are several out there. We spoke about these guys, frontal goggles. One of the crucial stages of working up a DISC patient, regardless of the algorithm, is to establish whether there is spontaneous nystagmus present or not. This is a watershed examination, as you saw, and that really determines everything after this examination in terms of workup. So it's pivotal to get it right. In most cases, you'll be able to see the spontaneous nystagmus with the naked eye, but it's not always like that. And specifically, if the patient presents late into the scenario with 1-2 days of ongoing dizziness, the system has had time to adapt somewhat, and the spontaneous nystagmus might be quite subtle. What the nystagmus, what the Frenzel goggles do is take away the ability to focus on anything, and that exacerbates the nystagmus, at least in peripheral lesions. And it also adds a bit of a light and sort of a good setting for you to correctly characterize the nystagmus and actually see what's going on. So really good to have. When we're talking about the third tool, the limited amount of clinical tests, it's really not much. And you are able to learn this if you are not already confident in this. Neurological exam and ear exam is what every doctor should be able to do, obviously. But for an emergency physician, it's also really important to be able to characterize and identify spontaneous nystagmus using Frenzel glasses. Thirdly, a Dix Hallpike of good quality is paramount. I think most feel quite comfortable with that. You could also add the Hedral test to check the lateral canals. Shalong is just orthostatic hypotension that comes into play sometimes. And thirdly, the HINTS battery is the kind of test that needs most training and most experience to be able to master. So that's really where you should put your focus when you go home and train. And keep that afresh as well. If you don't see enough patients in a while, just go over it mentally and maybe even train, because it's really it's quite difficult to get the right speed and the right stop in the motions. You might have... Do we have the microphone? Yeah, I could just repeat the question. Actually, especially when they're very dizzy. Yeah, absolutely. Sometimes it could be really tricky to examine any dizzy patient. If they have some truncal ataxia as well and not being able to sit up, it's really difficult. But then, on the other hand, it's almost always quite obvious. Then, so, yeah. All right, how about this guy? Can we not just rely on the neurologists to do all of this for us? If you happen to work in a center with 24/7 coverage of a really interested group of neuro-ophthalmologists, absolutely. But that's not the case for any of us, right? And unfortunately, most neurologists, or I wouldn't say most, but a good few of the neurologists aren't particularly interested in dizziness, and they don't really see that as a primary neurology state. And they might be right. I mean, given the pretest probability here, it's not very likely that these patients have a stroke in the first place. Working up the undifferentiated patient that presents to the emergency department and risk stratifying that patient, that's not the neurologist's expertise, that's ours. So we should really feel really comfortable doing this, and it's our work, so we can't really ask someone else. We can't do neuroimaging to help us. We can't ask the neurologist to do anything. You can get the ENT on board, but it'll take quite a while to get them to examine the patient, and they're not particularly interested as well to see the undifferentiated patient. All right, that's what I have, and yeah, we could just, if there's any questions, obviously, we'll do that. Yeah, all right, we have one at the far. Let's see, my left arm isn't really good at the moment. Let's see. Oh, that's
Great
10
throw.
point to me. All right.
I have jag kan ta på svenska. Jag har en praktisk fråga. Jag vet inte om ni andra har samma problem. Våra Frenzel-glasögon är sönder 80-90% av tiden. Är det några som lyckas lösa det? För att vi i teorin ska vi använda dem, men de funkar aldrig. Är det någon som har köpt? Ja.
Oh, yeah.
Nu råkar jag vara chef på en av landets största akutmottagningar och jag ser till att vi har 2 stycken videofränsel hela tiden så att den ena kan vara på reparation för de går sönder när man härjar med dem. Men jag har inte kommit under en lösning för ungefär 200 000, men jag tycker att den bör finnas på plats.
Yeah. So, I mean, obviously, if you have the resources to buy video frontals, that's very sensitive, and you could also document your findings, so it's really good. But, you know, at least try to sort out regular frontals. It's not very expensive. You could buy a bunch of them for quite low cost, and just so if they get stolen or broken, you could potentially just replace them then.
Can I add a comment while I still have it? I actually agree with basically everything you said, which is uncommon in a vertigo lecture. Thank you. Just one thought. You need to be a little bit cautious, in my opinion, with being too. You need to be careful with the timing and the triggers, because the dissipations, especially the elderly, in my opinion, have a tendency to describe a constant component of a clearly periodic vertigo. And also, there's the one that should have a triggered describe a constant component, and the one with the constant often get worse when they move. Yeah. So there might be components of both, and also just be cautious.
Yeah, I mean, I totally agree. And the elderly patients, as we all know, in any presentation is much more difficult, and you need to take your time with the history and the examination. But you're generally, I think you agree, you're generally able to lean towards one side of it. And obviously, there are a good few cases where the dizziness has been going on for a long time, perhaps, and they don't trust themselves walking, and you end up with a diagnosis of BPPV. So it's not always straightforward. But I mean, I think the take-home message is to downplay the risk of a stroke in most patients with the pretest probability, and emphasize the ability for us to sort of decrease that risk even further, just using our own clinical tests and knowledge about how to work up these patients, and not to rely on neuroradiology. Brilliant. Let's have Gerald first.
My big problem, mitt stora problem är Apples manöver på BPPV, och då tänkte jag komma tillbaka till din alltså din föreläsning om antiemetika. Finns det någon evidens i det specifiska fallet av vestibulärt syndrom eller BPPV att antiemetika hjälper? För att det gör det ofta svårt att göra en Apples. Patienterna skriker, de kräks. Jag har använt spritos för det mesta.
No, I mean, the question is really good. Does antiemetics have any place for the treatment of nausea in relation to dizziness? And I have had a look at some of the evidence there, and I think that the broader conclusion is that yes, it possibly helps in the short term, but it also risks at least to prolong the symptoms and delay the recovery. So the general expert opinion is that if you can't not use them, it's better in the long term for the patient, but in the acute setting, you're welcome to use them. I'm not sure if there's any RCT showing that any particular drug is superior to another. We have a few minutes left if there's any other question. There was someone up there previously. Yeah. There you go.
Det var mest kommentar till fränsel som är sönder. Det finns ju ett fattigmans fränseltest som är att man sätter ett papper alltså ett vitt papper framför patienten, för det tar bort lite av de här visuella ledtrådarna, så det kan man använda.
Yeah.
Det är lite billigare än glasögonen.
You're quite right. And I mean, if you don't have anything else, that's better than none, because it, as you say, take away a bit of the ability for the patient to focus. And specifically, if you then let the patient look to the right, as you always should when you examine the patient, look to the right and to the left, and you'll just hold the paper here, and hopefully that will take away some of the ability to focus. And in front, I'm not too sure, then I would just use a wall that's uniformly colored, because the paper is just a bit too small for the patient to sort of not be able to focus. Yeah. But good a good solution if you're not equipped with Frentzels. Anything else? No, I really, yeah, okay, one final.
What do you think about the patients that doesn't fit any of the criteria? I mean, when you can put them into one of those boxes.
Yeah.
And it's a patient that's 70 years old and really can't go home. Should you examine them for a stroke the next day with an MRI, or what are your conclusions?
Yeah, so that is a challenge. I mean, we're not sure yet. The research is developing in this area. There are some Asian studies where they're sort of MRIing everyone and just finding a lot of minor lesions. It's unclear how relevant those lesions were because they have a lot of sort of additional findings that wouldn't really explain the patient's symptoms. And we also have some knowledge about patients with dizziness that we are not able to diagnose and we send them home. They do have a slight increased risk of coming back with a stroke. So it's really important to take it seriously. And in the elderly population, it's possible that we're missing a small fraction of strokes there. So if you have concerns and your gut feeling is just like, okay, this patient needs some further evaluation, I would advocate for that probably. But there's no sort of concise guidelines or good evidence to support what to do in that situation. Okay. Thanks a lot. And I really hope that you take the opportunity to look at this literature because you'll have a hard time convincing anyone else about this. But I understand this recording will be available online later, so you could recommend your colleagues to have a look at this and check the literature yourself. And good luck. All right, thank you.